Good morning. We'll go ahead and get started this morning. I want to welcome everybody to this meeting of the Physician Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Angelo Sinopoli, and I'm one of the co-chairs of PTAC, along with Lauren Harding, who is actually joining us virtually. Lauren, at this point, I'm going to turn it over to you for opening remarks.
Thank you so much, Angelo. Since 2020, PTAC has been exploring themes that have emerged from stakeholder-submitted proposals over the years. After each theme-based discussion, the committee releases a public report to the Secretary of HHS with its findings and recommendations. Soon, PTAC will be posting its September 2023 report to the Secretary on encouraging rural participation in population-based total cost of care models, or TCOC models, on the ASPE PTAC website. In addition, PTAC will be posting a series of issue briefs summarizing key insights from the committee's work on developing and implementing total cost of care models. As we know from previous PTAC theme-based discussions and proposals, providers and organizations face challenges with addressing the needs of patients with complex chronic conditions or serious illnesses, particularly for total cost of care models. We also know that this topic is of interest to the Innovation Center at CMS. We're honored to have Dr. Liz Fowler, the Deputy Administrator of CMS and Director of the Center for Medicare and Medicaid Innovation, here with us today to give some opening remarks. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Welcome, Liz.
Thank you so much. It's really great to be back with PTAC for the second public meeting of the year and to continue learning from the panel and discussions that PTAC has very thoughtfully lined up. I was just remarking that you chose nice time of the year to be here, June and then back in September. So you're missing the hottest part of DC. But before turning to the topic of this session, I want to thank the committee for the robust discussion we had back in March focused on performance measurement. In particular, thanks for inviting the CMS senior physician leadership to speak on a panel about the CMS quality strategy. Our quality team has been talking about that panel and some of the points raised in other panel discussions ever since. And thanks also to the ASPE team, the ones who coordinate these PTAC discussions on behalf of HHS. We all share a common vision of transforming a health system to one that delivers the high quality care for all patients. As the value-based care landscape has shifted, so has the work of the Innovation Center and also the nature of our partnership with PTAC. The Innovation Center has moved away from its let 1,000 flowers bloom approach, and we've moved into the sort of second decade of our work. And PTAC has been really instrumental in sharing their expertise in areas that we're also focusing on, like the lessons learned from the first decade, how to expand what we know works, how to close the gaps in some of our portfolio, and how to address some of the more complex and vexing issues we face in trying to expand initiatives and innovations from our models when we know that they're working. With all that in mind, I'm really looking forward to the discussions over the next couple of days focused on beneficiaries with serious illnesses and complex chronic conditions. This has been an area that is top of mind for us as we assess the impact of current models and develop new models to improve care for these particularly vulnerable beneficiaries. The team is excited to share some of our lessons learned from CMMI model tests as they relate to seriously ill populations, including findings from our model evaluation reports that we're seeing in models we're testing now, what we're seeing in models we're testing now, and those about to start, like the guide model that starts July 1st. And also, it's important to focus on what we've learned about what doesn't work or what hasn't worked. Tomorrow, you'll hear from us about some of our prior efforts, like the Medicare Care Choices Model, MCCM, and the Independence at Home demonstration, both of which demonstrated improvements in beneficiary quality of care, but also both experienced challenges associated with trying to evaluate models with limited participation. We see a need for palliative care to be incorporated more broadly into the care of patients with serious illnesses. Better integration of palliative care throughout the continuum of illness can help support and manage different aspects of care, whether that's physical, psychosocial, or even spiritual. And as you're going to hear from my colleagues tomorrow, we know one of the key barriers to low use of palliative care at the end of life is low referral rate by primary care providers. In response, we've provided flexibilities in some of our models, like the ACO REACH and Kidney Care Choices model, that encourage greater use of palliative care and concurrent care during a hospice stay. And we included those flexibilities in the hospice benefit component of the Medicare Advantage value-based insurance design, or VBID model. Unfortunately, the VBID hospice component was impacted by limited participation and operational challenges, and we had to make the difficult choice to end the model early. So that model will conclude at the end of this year. Despite this setback, we plan to evaluate the model for lessons learned and to determine whether it met the model's goals. We also know that seriously ill beneficiaries require unique care delivery approaches. We're particularly pleased that the GUIDE model, focused on people with dementia and their caregivers, has been supported by palliative care clinical organizations and it is the first model to address all the elements they recommend for serious illness care. As we continue to innovate, we think some of the most promising opportunities lie in building capacity, expertise, and relationship with primary care providers. So in sum, this has been a vexing problem, but it's as important as it is hard to solve, which is why we're really glad it's at the center of your discussions these next 2 days. There's a lot to learn, so we're really happy that you're taking this topic up. We look forward to the committee's discussion over the next 2 days and what it will teach us at the Innovation Center. Thanks very much.
Thank you so much, Liz, for sharing those remarks. We appreciate your continued support and engagement, and we look forward to continuing to collaborate with the Innovation Center. For today's agenda, we will explore a range of topics related to addressing the needs of patients with complex chronic conditions or serious illnesses in total cost of care models, including care delivery needs of patients who account for the top 5% of Medicare spending, strategies for improving patient-centered care, care delivery, and health outcomes, optimizing the use of post-acute care, palliative care, and end-of-life care, approaches for measuring performance and quality of care, and incentivizing improved outcomes and delivery system transformation. The background materials for this meeting can be found, including an environmental scan, posted online on the ASPE PTAC website's meetings page. Over the next 2 days, we will hear from many esteemed experts with a variety of perspectives, including the viewpoints of previous PTAC proposal submitters. Tomorrow, several staff from CMMI will be discussing lessons learned from their serious illness models. I also want to mention that tomorrow afternoon will include a public comment period. Public comments will be limited to 3 minutes each. If you would like to give an oral public comment tomorrow but have not yet registered to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. The discussions, materials, and public comments from the June PTAC public meetings will all inform a report to the Secretary of HHS on addressing the needs of patients with complex chronic conditions or serious illnesses in total cost of care models. Over the next 2 days, the committee will discuss and shape our comments for the upcoming report. Before we adjourn tomorrow, we'll announce a request for input, which is an opportunity for stakeholders to provide written comments to the committee on addressing the needs of patients with complex chronic conditions or serious illnesses in population-based total cost of care models. Lastly, I'll note that, as always, the committee is ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters. allowing flexibility depending on the level of the detail of their payment methodology. You can find information about how to submit a proposal on the ASPE PTAC website. At this time, I would like my fellow PTAC members to please introduce themselves. Please share your name and your organization. And if you would like, feel free to describe any experience you have with our topic. First, we'll go around the table, and then I'll ask our members joining remotely to introduce themselves. I'll start. I'm Lauren Hardin. I'm Chief Integration Officer for HC2 Strategies. I spent the better part of the last 20 years focused on high-cost, high-needs populations, including developing a successful complex care model that scaled to multiple states and was recognized by the National Academy of Medicine, was part of the team that established the National Center for Complex Health and Social Needs. And I currently partner with government, states, and communities and health systems, designing and standing up models for complex and underserved populations. Next is Angelo.
Thank you, Lauren. My name is Angelo Sinopoli. I'm a pulmonary critical care physician by training. Spent most of my career working in large health systems, integrated health systems, developed several large clinically integrated networks along with enablement companies to help support those networks, and particularly focused on those high needs patients. I am presently the Executive Vice President for Value-Based Care at Cone Health. Thank you. Walter?
Good morning, everyone. My name is Walter Lynn, and I am the founder of Generation Clinical Partners. We are a group of medical providers in the greater St. Louis area that specializes in the care of patients with complex chronic conditions and serious illness residing in nursing homes and assisted living facilities. Our mission is to help these senior living organizations transition into the world of value-based care through a medical model that focuses on delivering high value, responsive primary care to this frail patient population. I also serve as the medical director for a PACE program and the medical director for a provider arm of an institutional special needs plan, and am an active member of the Society for Post-Acute and Long-Term Care.
Hi, everyone. Chini Puluru. I'm a family physician by trade. I led a large medical group in clinical delivery as well as value-based care transformation, a multi-specialty group named Dooley Health and Care, as well as most recently was chief clinical executive at Walmart, powering COVID response as well as powering the growth of Walmart Health. Currently serving as president of CP Advisory Services, advising and serving on the board of multiple organizations that do value-based care transformation, including Stellar Health and physician retention, such as Physician X. And I recently co-founded a startup named My Precious Genes in Genetic Counseling. Thank you.
Good morning. I'm Lindsay Botsford. I'm a practicing family physician in Houston, Texas with Amazon One Medical. I currently work as a regional medical director supporting our practices across the Midwest and Texas. This includes 6 practices where we exclusively care for older adults on Medicare and full risk contracts. I also chair our ACO REACH governing body as part of the IORA Health Network. Prior to that, I worked in residency education and large health systems and ACOs, and I currently serve as the president-elect of the Texas Academy of Family Physicians.
Good morning. I'm Terry Lee Mills. I'm a family physician. I'm owner of Strategic Health Consulting and have come through medical group leadership of integrated health systems in several states. I've been spending my career leading practice transformation and clinical informatics, and have had the joy of leading through and trying to operate to multiple CMMI pilots over the last 20 years.
Good morning. I'm Dr. Larry Kaczynski. I'm a gastroenterologist by training. I spent most of my career in private practice in the Chicagoland area, building one of the largest GI practices in the country. For the last 10 years, I've been involved with value-based care from a specialty point of view, having founded a company named Sonar MD, which arose out of a PTAC proposal back in 2017. Currently, I am retired from practice. I I'm on the board of Sonar. I'm also the chief medical officer of a startup called Jonah, which is in the microbiome space. And this is my third year on the committee.
Good morning. I'm Dr. Jennifer Weiler, emergency physician by training. I'm the Chief Quality Officer for UC Health's metro area in the Rocky Mountain region. I'm also co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions at the point of care. I'm a tenured professor at the Colorado School of Medicine and a former co-developer of an alternative payment model that was reviewed by PTAC and endorsed by this committee and delivered to CMMI.
Good morning, everyone. My name is Dr. Jay Feldstein, emergency medicine physician by training as well, and spent 15 years in the health insurance world. And for the past 10 years, I've been the president of Philadelphia College of Osteopathic Medicine, trying to integrate value-based purchasing into a medical school curriculum. Thank you.
Thank you, everyone. Next, let's go to Josh, who's joining us on Zoom.
Good morning, everybody. Josh Lau, internal medicine physician at the University of Texas Southwestern Medical Center, where I'm a professor of medicine and public health, lead the division of general internal medicine, and direct a program called the Program on Policy Evaluation and Learning. I think those things reflect what I've worked on over my career, both in doing what I hope to be impactful research on the topics of value-based payments and payment policy overall, as well as working with private and policy public makers on how to design and implement and then evaluate those programs. And in that work, have worked with IDNs or integrated delivery networks, as well as kind of public entities on that. Excited to join today.
Thank you, Josh. Thank you all. One of our members, Dr. Jim Walton, is unable to join us for this meeting, but we wanted to thank him for all of his contributions to the meeting preparations. Now let's move to our first presentation. 4 PTAC members served on the Preliminary Comments Development Team, or PCDT, which has worked closely with staff to prepare for this meeting. Walter Lynn was the PCDT lead, with participation from Lindsay Botsford, Lee Mills, and Larry Kaczynski. I'm thankful for the time and effort they put into organizing today's agenda. The PCDT will share some of the findings from their analysis to set the stage and goals for this meeting. PTAC members, you will have an opportunity to ask the PCDT any follow-up questions afterwards. And now I'll turn it over to Walter.
Thank you, Lauren. I would like to start by expressing my deep gratitude to my fellow PCDT and PTAC members, ASPE and NORC staff for the tremendous amount of work putting together this presentation, as well as what promises to be outstanding 2 days of learning from our subject matter experts. In terms of the objectives for this meeting, I won't spend too much time on this because Lauren reviewed them in her introductory remarks, but suffice it to say that we're here to understand better the disproportionate impact that the most costly beneficiaries that Medicare insures have on Medicare spending, and understand the challenges related to improving care for this population of patients with complex chronic conditions and serious illness, and identify the opportunities for optimizing the use of palliative and end-of-life care in this population of patients. In terms of the context for this meeting, the statutory mission of PTAC is to make recommendations to the Secretary of Health and Human Services on proposals for physician-focused payment models submitted to the committee. Of the 35 proposals PTAC has received, at least 13 of them have included components related to addressing the needs of patients with complex chronic conditions and/or serious illness. PTAC is excited for the opportunity to do a deep dive on this theme during this 2-day meeting. In terms of the agenda for this PCDT presentation, I will first start by reviewing relevant background information and defined terms that will be used throughout the public meeting. Next, I will present findings from an original descriptive analysis of high-cost Medicare beneficiaries commissioned by PTAC for the purposes of this meeting. This will be followed by a discussion about the challenges and opportunities for caring for this patient population. And finally, I will conclude with a brief overview of potential performance measures and payment models relevant to this population. So first, some definitions. PTAC has defined patients with complex chronic conditions as those with more than one chronic condition lasting 12 months or more, who usually require complex care involving multiple health providers across different specialties and settings of care. We have defined patients with serious illness as patients with advanced illness who are in their last years of life. These patients are prone to acute events that can impact their healthcare needs and drive up their healthcare costs. I'd like to spend a bit of extra time on this very important slide, showing some MedPAC data about how the high concentration of costs amongst a very small group of Medicare beneficiaries drives Medicare spending. This slide is actually the raison d'etre for this two-day public meeting. So according to MedPAC data, the most expensive 1% of Medicare fee-for-service beneficiaries account for 17% of its spending, while the most expensive 5% of beneficiaries account for 44% of spending. The top 10% of most expensive beneficiaries that Medicare insures account for almost 2/3 of fee-for-service spending. While at the other end of the spectrum, the least costly 50% of Medicare beneficiaries only account for 3% of program spending. Unfortunately, the fee-for-service system does not adequately incentivize providers to focus on this small proportion of Medicare beneficiaries driving most of its spending. For example, a physician can probably see 2 to 4 healthy Medicare patients in the same time it takes to see and really care for one complex patient with serious illness. In part because of these historical payment incentives, complex patients with serious illness often receive much of their care in the emergency room or hospital, which explains why, in part, they are so high cost. The good news is that payment incentives can be much more aligned under value-based care and can better support care models that achieve both higher quality and lower cost outcomes for this expensive patient population. PTAC has classified high-cost Medicare beneficiaries into 3 working definition categories. Those with complex chronic conditions, which may be controlled or uncontrolled. Examples in this category include late effects of stroke, diabetes with complications, and non-healing complex wounds. Secondly, those with serious illnesses is the second category, which may be in active treatment, palliative care, or hospice. Examples of this category of patients include end-stage renal disease patients, patients with advanced heart failure, and patients with metastatic cancer. And those who experience a time-limited catastrophic health event, such as a major trauma from a motor vehicle accident, is a third category. We will not be focusing on this latter category of patients. This slide shows a Venn diagram of these 3 patient populations. The focus of this meeting will be on the intersection of these 3 patient populations, namely high-cost patients with either complex chronic conditions that are typically uncontrolled or patients with serious illness undergoing active treatment, or both. Again, our meeting will not be focused on high-cost patients who are high-cost because of a time-limited catastrophic health event, or patients with complex chronic conditions or serious illnesses who are not high cost. Now, this may be obvious, but it's worth mentioning that effective care models treating patients with complex chronic conditions or serious illnesses do not somehow magically cure the incurable, but rather they try to move these patients to a lower cost status by controlling their complex chronic conditions, delaying progression of their disease, reducing treatment complications, and or providing goals concordant end-of-life care. This slide provides an example of a patient care journey to help make all of this a bit more concrete. In this example, a 74-year-old man with a history of hypertension, diabetes, and chronic kidney disease has an acute event such as a heart attack. Genetics, lifestyle choices such as smoking and a poor diet, and health-related social needs may have contributed to this acute event. After the heart attack, this patient develops heart failure. At first, this new condition is well controlled with medications, and so the patient does not move into the high-cost category. Over time, though, as a result of perhaps disease progression or factors like the inability to afford medications, the patient may start having multiple exacerbations of heart failure, requiring frequent hospitalizations and post-acute care episodes. Now, by age 85, other organs in his body, like his kidneys, have become affected, necessitating dialysis. Similarly, poor circulation has resulted in severe peripheral vascular disease complicated by large non-healing wounds with infection of the bone and gangrene, requiring leg amputation. And the patient has now developed a cardiac arrhythmia like atrial fibrillation, increasing the risk of stroke and more frequent heart failure exacerbations. Finally, after a massive stroke at age 90, resulting in the need for 24/7 total care and nursing home placement, the patient and his family decided to focus on symptom relief and comfort care rather than prolong the suffering with the placement of a feeding tube. In this example, the patient passes away on hospice peacefully at home, surrounded by his friends and family. Now, I will be circling back to this patient care journey later in my presentation, so please try to remember some of the details. Up until now, I have defined and described the population in focus for our theme-based meeting, namely high-cost patients with complex chronic conditions or serious illness. Now, some good news. Although expensive, studies have found that the majority of potentially preventable healthcare spending is in this exact patient population. Organizations in total cost of care models have recognized the disproportionate impact these patients have on healthcare spend and have deployed effective care models to both improve the quality and lower costs for this population. We all look forward to learning more from our many subject matter experts involved in such care models over the next 2 days. Next, I am very excited to present findings from an original analysis of high-cost Medicare beneficiaries commissioned by PTAC for this meeting to help us better understand this population in more detail. This study includes calendar year 2017 to 2023 data from Medicare fee-for-service beneficiaries continuously enrolled in Medicare's Parts A and B, allowing for death in each year. The total spending is calculated by the sum of Medicare program spending and beneficiary out-of-pocket spending. This study had 3 objectives. 1, describe the most expensive Medicare fee-for-service beneficiaries in more detail. 2, examine trends in spending over the study years. And 3, look at how stable this cohort is from year to year. The table in this graph, in this slide, shows that Medicare spending increased during the study years, albeit not in a straight line, and the number of beneficiaries decreased, resulting in a per capita spend of almost $13,400 in 2017 to $16,200 in 2023. This represents a 3.2% compound annual growth rate for overall per capita fee-for-service Medicare spend during the study years. This slide shows the concentration of top spenders in the study years. A few takeaways. Focusing on the right-handmost 2023 year data, the top 5% of most costly fee-for-service beneficiaries in the green accounted for about 40% of all Part A and Part B spending. The next 5% in the red accounted for 17%. And so together, the top 10% accounted for close to 60% of spending, similar to the MedPAC data that we reviewed earlier. The bottom 90% of fee-for-service beneficiaries accounted for 43% of all spending. Interestingly, this distribution held pretty much constant throughout the study years, which included the pandemic years. This slide shows the average per capita spend in the study years. A few takeaways. In 2023, the average per capita spending for the costliest 5% was over $129,000, as compared to the about $54,000 for the top 6 to 10% and about $16,000 for the overall fee-for-service per capita spending. Over the study years of 2017 to 2023, the annual growth rate in per capita spend for the costliest 5% of spenders was 3.6% compared to 3.3% for overall fee-for-service per capita spend. Now, doing a deeper dive, this slide shows selected characteristics for the costliest Medicare beneficiaries compared to the average fee-for-service beneficiaries in 2021. Takeaways. The top 5% costliest beneficiaries had over 4 times the mortality rate of the average fee-for-service beneficiary, 22% versus 4%. Black, non-Hispanic, and dual-eligible beneficiaries were disproportionately represented in the top 5%. The top 5% costliest beneficiaries had almost 3 times the number of chronic conditions versus the average fee-for-service beneficiary, 8 conditions versus 3. This slide shows spending distribution for Parts A and B services for the top 1%, 2 to 5%, and 6 to 10% of costliest Medicare beneficiaries over the study period. Some takeaways. The spending distribution remained relatively constant in the top 2 to 5% and 6 to 10% categories. But on the leftmost graph, we see that for the top 1%, Part B drug spend in the purple increased by 10 percentage points, with a significant drop in Part A hospital spend in the green. Of note, Part B drug spend includes those drugs that are typically provided in a clinician's office. PTAC was surprised by this finding and feel that it warrants deeper investigation, as the value of increased Part B drug spend is unclear at this point. Finally, this analysis looked at how stable the top 5% costliest beneficiaries is year to year. Compared to the previous calendar year, 27 to 29% remained in the top 5% category, while an additional 12 to 13% moved into the top 6 to 10% category. Thus, about 40% of the costliest beneficiaries remained in the top 10% in the following calendar year. This is actually critical from a care model design perspective. I will note in passing that although approximately 60% of the costliest beneficiaries moved out of the top decile in the following calendar year, preliminary findings seem to indicate that a significant proportion of these patients passed away. So stay tuned for further analysis of this data. Finally, the analysis looked at the top 5% costliest beneficiaries who stayed costly versus moved out of the top decile spending. Beneficiaries in the top 5% who remained costly in the following year were on average younger, had more chronic conditions, were more likely to be dually eligible and non-Hispanic Black, and to live in zip codes with lower socioeconomic status. Next, we will look at the challenges and opportunities for caring for this patient population. As one would expect, there are many challenges associated with caring for this complex population of high-cost patients. From a model perspective, these include prospective identification, and robust risk stratification, since the composition of this cohort does not remain the same from year to year, as I just detailed. Implementing a multidisciplinary care model to provide team-based goals concordant care that addresses a need for care coordination, specialty integration, and safe care transitions is another challenge. And effectively engaging patients and caregivers in addressing their health-related social needs and clinical care is also a challenge. From our environmental scan, PTAC has found evidence that intensive outpatient team-based medical care and or formal disease management programs can improve health and reduce medical costs for patients with complex chronic conditions and serious illness. And an increased focus on palliative care and hospice can do the same for patients with serious illness. Of course, these opportunities to improve care are not mutually exclusive. With respect to an increased focus on palliative care and hospice for the seriously ill, the slide shows two of many possible trajectories for end-of-life care. Now, recall the congestive heart failure patient care example I described in the first part of this presentation. After the patient's massive stroke at age 90, resulting in the need for 24/7 care, the patient and his family decided in that example to focus on symptom relief and comfort care rather than prolong the suffering with placement of a feeding tube. This is depicted in the soft landing trajectory at the bottom of the slide, where more and more palliative care is in focus with final care under hospice. In this example, the patient passes away on hospice peacefully, surrounded by friends and family. Contrast that to the hard landing trajectory at the top of the slide, where in this example, the patient's family decides to actually go forward with placement of a feeding tube and continue full aggressive care, including dialysis and frequent hospitalizations for aspiration pneumonia, wound infections, and heart failure exacerbations. In this example, this patient ultimately succumbs at the age of 91 in the ICU on a ventilator with all sorts of lines and tubes in him from overwhelming septic shock with multi-organ failure. The palliative care literature is replete with studies showing that aggressive medical interventions at the end of life often do little more than prolong the patient's suffering without significantly improving health, function, or survival. We'll now look at some strategies commonly employed under value-based care to improve outcomes for this costly patient population and ongoing CMMI models by the three different subgroups represented by the areas 1, 2, and 3 in this slide. Again, area 1 is the intersection of high cost and chronic care and are those patients usually with uncontrolled complex chronic conditions. Area 3 is the intersection of high-cost patients with serious illness under active treatment. And area 2 are those with serious illness and complex chronic conditions who are high cost. Before getting to the strategies, though, I would like to highlight some important objectives for improving the care of this costly patient population. These include providing goals concordant care, delaying progression of chronic diseases, catching acute exacerbations early to enable outpatient treatment, and reducing treatment burden and complications of treatment. Some commonly employed strategies to achieve these objectives in this population of patients include involving specialized multidisciplinary care teams with a focus on care coordination, patient navigation, medication management, and frequent goals of care discussions. As patients progress to serious illness, palliative care and hospice become increasingly important. These care models are very difficult to operationalize under fee-for-service and typically require some sort of value-based payment arrangement. Examples of such payment arrangements are seen in the various CMS and CMMI model column on the right of the table. These include chronic and institutional special needs plans, the TEAM model, which stands for Transforming Episode Accountability Model, the PACE program, which is a program of all-inclusive care for the elderly, ACO REACH and high needs DCE, Medicare Advantage value-based insurance design, or the VBID model. Under seriously ill models, these include the kidney care models, which include comprehensive ESRD care, kidney care choices, and end-stage renal disease treatment choices, and the oncology care model. Lastly, this session will conclude with a brief overview of performance measures, financial incentives, and payment models relevant to this patient population. This table shows some possible performance measures for this patient population. The 4 categories of performance measures can be seen in the 4 row headings, namely process measures, outcomes measures, utilization measures, and cost measures. PTAC has provided some examples of possible population-based, episode-based, and palliative end-of-life care performance measures for each of these categories, as can be seen in this table. Under process measures, a population-based measure might be, for example, the percentage of patients with advanced care planning discussions documented. An episode-based measure might be the percent of transitional care management visit completion rate. And under palliative end-of-life care, a measure might be hospice staff visits to patients in their final 3 days of life. A population-based utilization measure might be inpatient admissions per 1,000. An episode-based measure might be 30-day rehospitalization rates, and a palliative care end-of-life care measure might be percentage of patients admitted to hospice for less than 7 days or greater than 1 year. Many methodology challenges exist in the design of value-based payment models for this costly patient population. These include attribution challenges, since multiple providers may be involved in overlapping episodes of care and in multiple settings of care. Potential approaches to addressing this challenge might be shared attribution by the PCP and specialists team, and concurrent episode-based attribution. Aligning incentives across settings of care solutions might include rewards for participation in transitions of care programs and increasing incentives for appropriate palliative care. Benchmarking the costliest beneficiaries against the general Medicare population hides the disproportionate impact these patients have on spend. And so it's important to benchmark like with like. In other words, benchmark similar patient populations to allow for appropriate comparisons. Appropriate risk adjustment is necessary to allow for appropriate provider payment in this very costly patient population. Potential approaches to addressing this challenge include stratifying practices into risk groups using HEC risk scores for attributed patients and using complexity tiers. Retrospective reconciliation denies the use of real-time data to manage performance. And a potential solution might be to implement more models that offer prospective payment methodologies, such as per beneficiary per month payments or bundled payments. Designing effective scalable models for the costliest 5 to 10% that we are focused on is exponentially exacerbated in rural locations where providers often have small patient panel sizes to begin with. A potential solution might be incorporating more multi-payer or all-inclusive models, all-inclusive payer models. And identifying effective payment models within total cost of care is a challenge that can be addressed by models that focus on and offer incentives for providing care coordination and transitional care services. Finally, I would like to leave everyone with a few big picture takeaways to prepare us for our upcoming panel discussions. Firstly, Medicare spending is highly concentrated. The top 5% of Medicare fee-for-service beneficiaries account for 40% of Medicare Parts A and B spending. Average per capita spending for the top 5% is growing faster than for the overall fee-for-service population. Approximately 40% of beneficiaries in the top 5% remain in the top decile of spending in the following year. Secondly, the majority of potentially preventable spend is among this high-cost beneficiary population. But historically, fee-for-service has not promoted the efficient care of this complex patient population and those with serious illness because of the payment incentives involved in volume rather than value. We have two big goals for our two-day meeting together. We want to understand existing effective care models that are efficiently addressing the needs of this population in terms of how they work and the outcomes they're able to achieve. And we want to explore further opportunities for developing new payment models that can improve quality of care and lower costs for this patient population. This slide lists the various panel discussions and listening sessions that we will be having over our two-day meeting. And we, as a committee, very much look forward to learning from our subject matter experts who are already, in many cases, involved with this work. Thank you.
Thank you so much, Walter, for an excellent presentation. And also thank you to Lindsay, Lee, and Larry as part of the PCDT. Lindsay, Lee, Larry, are there any additional comments you'd like to add to the presentation?
No, I think Walter said it all very well. He did most of the work.
I know you all. I know you all worked on this. For the committee members, do any of you have follow-up questions for the PCDT? And to indicate if you have a question, please raise your name tent, flip it up, or if for Josh on Zoom, please raise your hand. And it's difficult for me to see your tent. So Angelo, if you see a tent raised, if you wouldn't mind calling on that person.
Sure. Jennifer.
Thank you so much for a very interesting presentation and analysis. I'm curious, when you were going through this process, what surprised you about the findings that you presented today? Something maybe that was unexpected.
So I'll also let the rest of the PCDT opine if they would like to, but I'll start by saying, actually, looking at the original analysis of Medicare claims data that was commissioned for this public meeting surprised me in a few ways. One, just the sheer expense of even the top 1% of spenders, $129,000 per capita versus the average is $16,000. So we're talking, multiples of the average fee-for-service spend. Even the top, the next category, the $54,000 average spend in the top, I think it's the top 5%, is also very, very expensive. What was also surprising was that only 40% of patients stayed within the top decile of most costly patients in the following year. I think that was original analysis. That was very interesting. Initially, there was some discussion amongst PCDT and the broader PTAC committee about the 60% that moved, dropped out of the top decile spending. And so we kind of look forward to further analysis. There's some initial data that suggests that maybe a lot of them died, but I think there's just not a lot of opportunity to both improve care and lower costs in this population of patients.
Thank you, Walter.
I'd like
Any
to
other-
make one more comment on Jennifer's question. I was surprised, very surprised by the slow growth in overall spend on the Medicare fee-for-service population from the years 2017 to 2023, an average of 3.27, which I would imagine is below the inflation rate for that period of time. So that was very encouraging. That being said, we are seeing a significant bulge in the component that's for Part B drugs. And it would be very interesting to see the same data for the Part D drugs, because I would imagine they're growing as well. But I was surprised that the non-pharmacologic medical expenses in the fee-for-service Medicare program only rose at 3.27%.
Any other questions from the committee?
Cheney?
Not a question, but another comment on the data. The arbitrage between the top 1% and the rest, I find incredibly surprising. The other thing, and to Larry's point, is that typically when we see hospital costs go down, we would think that that is a positive sign. The patients are being, treated better, kept out of the hospital. However, the Part B spend on drugs sort of balances that out. So it's not that necessarily they were being spent on stuff like palliative care or professional services, but on a unit cost rate of drugs. And so I think that is, and without prolonging life and without necessarily adding to a movement from that top 5% downwards that we could find. So, I think it definitely lends itself to asking questions about, are we just moving and shifting costs from what used to be a hospital cost center to now where we're giving high cost drugs?
And then briefly, Josh, we just have a minute or so before we go to break.
Great. I'll be very brief. I think great presentation. One reflection and maybe one comment for Walter and the PCDT. The reflection is, I think, as Walter alluded to, that 60% and really kind of having this analysis, which provides really important insight and thinking about kind of people that, quote, stay in the next year versus people who stay for, say, 2, 3, 4 years, to the extent that, I can't imagine a payment model or a delivery model only be around for 1 or 2 years. So over the life of what we might anticipate a model to be, 3, 4, 5 years, et cetera, what would the stable population be there? And perhaps there's future work to be done. I guess my question is really around this analysis being very important and framing everything around top utilization and spending. But what I appreciate about Walter's presentation was the focus also on the complex care needs. And I wonder, is there a world in which if we thought in the other way about people who have the most complex needs, or the highest needs, and we kind of thought about the top X% of those individuals in that population, if we might come to additional insights. So it's just another way of thinking about this population that moves us a bit away from cost, which I know is not the focus of this, but wonder if Walter has any initial reflections on that.
Yeah, Josh, I appreciate your question. I think the goal for all of us is to provide higher quality, more goals concordant care. It's our hypothesis that this type of care will also be lower cost care, because in part of what the palliative care literature shows around how aggressive interventions do very little to improve health and survival towards the end of life. And in fact, palliative care literature, hospice literature also shows that patients and their families are usually much more satisfied with care that follows a soft landing trajectory. In hindsight, both the family and caregivers report that it's much less traumatic, and so I think there's potentially a win-win here to not only focus on providing better care through improved care models for this expensive population, but also to lower costs at the same time.
Thank you, Walter. And I hear that Lee has a question. And again, if you can make that briefly, we're about ready to go to break.
Sure, thanks. I following up the question about what, struck us or surprised us, I was really struck, just as other people were, slides 15, 16, 17, looking at how the population changed over time. And I was struck especially on slide 17 that those that start out in the most expensive 1%, 40% are sticky the next year in the top 1%, but 60% have dropped out of the top 1% for various reasons, which makes me aware that building programs or pilots chasing today's costs or diagnoses is going to ultimately be unsuccessful. And in slide 17 points to characteristics that seem to predict who sticks in that top 1%. And so as we go through this conversation, thinking about things that have worked, what pilots or program tracks may be successful, it makes me think even lean into building pilots programs around characteristics, not diagnoses or today's costs, since that can be fleeting.
It's such an important point. I also strongly see the crossover of behavioral health and health-related social needs is impacting that. Excellent presentation, PCDT. We really appreciate all of your time and commitment in pulling this together and really setting a great foundation for our day today. At this time, we have a break until 10:30 Eastern. Please join us then as we have a wonderful lineup for our first panel discussion on providing patient-centered care for patients with complex chronic conditions or serious illnesses and total cost of care models. We'll see you back at 10:30.
Produced by the U.S. Department of Health and Human Services.